Okay, നമുക്ക് class start ചെയ്യാം. Yeah. Okay, so this is a scientist, Russian scientist called Gary Adabay. Is it clear, alle? Like, Akash?
Yes, sir.
Okay. About this is a scientist, Gary Adabay. He was a Russian scientist. He was actually a biochemist involved in plant biochemistry. But he was into in Russia, they took it into animal biochemistry as well. And during his research, he found out that in mice containing hepatic carcinoma, there he found that certain proteins are increased in number. So he started researching on it, and he found out that every mice with a hepatic carcinoma or teratoma is showing some increase in a protein. And he termed it as alpha fetoprotein. And later it was found that even in humans, this protein was increased during hepatic carcinoma. So they started researching on it, and they found out that this can be called as a tumor marker. So today's class is about tumor markers or tumor index substance. So these are the substances that is released from tumor cells. So whenever there is a tumor, like it can be at different stages of tumors that tumor markers can be released. So it can be classified into based on for what purpose that tumor marker is used. So tumor markers or tumor index substances, it is released from tumor cells, and it can be used for following purposes. Like it can be used for detection of cancer. For example, if a person is suspected to have prostate cancer, then we will be checking the level of prostate specific antigen in that person. Just one. Okay, if we are checking for prostate cancer, we can check for prostate specific antigen, which is a tumor marker for prostate cancer. So if it is elevated, it shows that the patient is having or the person is having prostate cancer. Or there can be like these are something like non-invasive procedure. We need not take biopsy. We need not take any invasive diagnostic therapy. Just we can look, we can check for tumor markers and know whether tumor is present or not. There is no risk of exposure by the way of X-ray or CT scan. We can check the blood for tumor markers, and we can say whether the patient is suspected to have tumor or not. There can be conditions in which tumor markers can be increased because these are substances which are produced normally also. So there can be conditions in which tumor markers can be increased. So in a way, it shows that the patient might be having or suspected to be having cancer. It doesn't confirm it. Or for other purpose of tumor marker is that it can be used for follow-up of cancer and to monitor the effectiveness of therapy. The classical example of this purpose is beta HCG in choriocarcinoma. What is choriocarcinoma, Alan?
Hello, sir.
Choriocarcinoma എന്താ? ഗസ് ചെയ്യാൻ പറ്റുമോ എന്ന് വെച്ചാൽ ലൈക്ക് ഐ ഡിഡ്ന്റ്, നിങ്ങൾ പഠിച്ചിട്ടുണ്ടാവില്ല, ബട്ട് സ്റ്റിൽ ആസ്കിങ്. ബീറ്റ എച്ച് സി ജി എവിടെയാണ് കേട്ടിരിക്കുന്നതെന്ന് പറഞ്ഞാൽ ചിലപ്പോ ഒന്ന് ഗസ് ചെയ്യാൻ പറ്റും. യൂട്രസ് അല്ല, ഏകദേശം അടുത്താണ്. ബീറ്റ എച്ച് സി ജി സാധാരണ നമ്മൾ ടെസ്റ്റ് ചെയ്യുന്നത് പ്രഗ്നൻസിയിലാണ്. ലൈക്ക് ബീറ്റ എച്ച് സി ജി, യാ, because placenta secretes beta HCG. That's why it is seen in pregnancy. So choriocarcinoma is carcinoma of placenta. Okay.
Yes, sir.
Thank you. So choriocarcinoma is cancer of placenta. So it was seen that some patients with placenta was having carcinoma, and it was found that such patients were having increased amounts of beta HCG because placenta is something which produces beta HCG, and it is used for detection of pregnancy. But it was found that beta HCG levels were very high, and what they found out that in earlier days we didn't know like whether it is caused by cancer or whether it is caused by any other disease, because they had a single term called cancer. What we see today as prostate cancer, ovarian tumor, uh, like neural cell tumor or anything, there was no such classification back then. Even in 1950s and 60s, they thought that there was only single disease, cancer. There was only a single treatment for cancer, because they didn't know that it was different causes for different cancers, and different cancers need different treatment. So when they found out that choriocarcinoma is there in some patients, they started giving treatment for it. And there was a scientist who found out that beta HCG levels were very high in those patients. But what they did was that they started giving treatment. Initially, in 1960s, scientists started giving treatment for choriocarcinoma, and it was found that the size was decreased. So they thought that the cancer was in remission phase. But there was a particular scientist, I searched for his name, but I couldn't get it. Like he was a Japanese American who came to America and started research on cancer. He found out that though in images, whether it is in CT or in X-rays or in ultrasound, though the cancer appears to be decreased in size, beta HCG levels was in normal. So what he did was that he continued treatment for choriocarcinoma patients till the beta HCG level was normal. So back then, the treatment was giving chemotherapy. They didn't know what was the correct dose. They started experimenting on it. They would give the chemotherapy in very high doses, the doses that we can't imagine today. Because back then they didn't know how to dose the medicine, because everything was an experiment. So they started giving high dose chemotherapy. Patient was having very high side effects of chemotherapy, but he didn't stop. He continued treatment till beta HCG was normal. So the first thing that Cancer Research Institute did was that to suspend him. To suspend him because he was giving treatment despite the size of cancer being reduced. They suspended him because he was giving high dose chemotherapy. But later, like almost 10 years later, they found out that patients in which he gave treatment till beta HCG was normal was having a good prognosis. They choriocarcinoma didn't appear in those patients, but in other patients in which chemotherapy was given only till size was reduced and beta HCG was still high, was having a relapse. Relapse means the return of cancer. So they started experimenting on beta HCG. They found out that beta HCG can be used to tell whether the treatment is appropriate or no. So again, the research on tumor cancers, tumor markers started. They found out that beta HCG can be used. There are even prostate specific antigen can be used to know whether the treatment is adequate or not, whether uh, the cancer is in regressive phase or not, or which treatment can be effective. For example, the last one, prognosis. Like in breast carcinoma, uh, when you like, I don't know whether any surgery class has been taken. The earlier surgery was Halsted surgery. Back then, in like many of you may be knowing, in 19th century till 19th century, we didn't had any anesthesia. Only thing was that if there was something, we do the surgery, and we didn't had any proper suture materials also. We'll be using some suture material. It may be adequate, it may not be adequate, but we use it. So there was no anesthesia, no proper suturing. So invariably, surgery means death. Like even then, like you may be heard of cesarean sections in the ancient times, but in those times, what they don't tell is that after cesarean section, the patient will be no more. Like like they don't know the suture techniques, or they don't know anesthesia, they don't know anything. Only thing is that they can remove uh, they can open uterus and take out the fetus. Similarly, in tumor also, they didn't know how to properly control it. So in the initial time, what they did was that they used to take out, like in earlier time of 20th century, they found out anesthesia, they found out suture materials and so on. But still, they thought that uh, tumor spread to adjacent structures. So they need to remove every structure that surrounds a tumor. So if there is breast tumor, what they did was that they removed the axillary lymph nodes, they removed the vessels there, they removed the muscles there, they removed the subcutaneous tissue, everything, skin, everything there. So they thought that after removing everything, the patient will survive. And later it was found out that surgeries like that may not be effective as we thought, because there is something like metastasis which was not known earlier. There is something like seeding which was not known earlier. There is something like skip lesions. There is something like lymphatic drainage, which means that even after we remove the adjacent nodes, it may not be the adjacent nodes to which it breaks. So such things were studied later, and later it was also found out that there are something called tumor markers which can be used for telling the prognosis of breast cancer. For example, if a patient is having breast cancer, but the estrogen receptor or progesterone receptor is present in that patient, that means that he has high chances of targeted chemotherapy. Targeted chemotherapy means that chemotherapeutic agents which attach to estrogen receptor or progesterone receptor have a better prognosis. So they started studying about estrogen receptor, they started studying about progesterone receptor, and so on. So, in a nutshell, tumor markers can be used for either for the detection of cancer. The classic example is prostate-specific antigen, or it can be used for follow-up of cancer, or to know whether the therapy that we are giving is effective or not. Because it is like we cannot imagine the scene that was earlier. Like in 1960s and 1970s, we'll come into it. But back then, they didn't know which treatment was effective. They started giving radiotherapy for some patients. They started giving surgery for some patients. They started giving chemotherapy for patients. And this was done separately also, because they didn't know what treatment was most effective for the patient. It was then that tumor markers appeared to be like it changed the scenario. It changed the scenario means that we could predict whether the treatment is effective, is adequate, the patient is in remission phase. Like the two terms that you have to remember in cancer is, one is remission, second is relapse. Remission means that the cancer is regressing, or the cancer doesn't grow anymore, it is regressing in regression phase. Relapse means in a patient who completed treatment, the cancer reappears. That means relapse of treatment. Okay, that should be kept in your mind. So we could predict it. We could predict whether the patient is in remission phase or relapse phase, or whether the therapy is effective or not. And later we found out that like it can be used for the prognosis of the patient. Like if the patient is having estrogen receptor, the patient is having a good prognosis. One thing is that we can have targeted chemotherapy. Second is that it was found out that somehow estrogen receptor positive patients was having a better result or better prognosis in the case of breast cancer, and so on. So these are the if tumor marker is asked, you should definitely write this, and also you should be knowing some of the tumor markers. That is for breast cancer. The classic example I will tell is that one is prostate specific antigen. Uh, Second is colorectal cancer and gastrointestinal cancer, in which carcinoembryonic antigen can be used. Liver cancer or testicular cancer, uh, alpha fetoprotein. As I said, it was the first tumor marker to be discovered. Like it was found out that uh, like the in hepatic carcinoma of a mouse, the alpha fetoprotein level was increased. So they started uh, researching on hepatic cancers in humans, and they found out that even in humans, alpha beta protein was increased. And another example is placental cancer or choriocarcinoma, in which human chorionic gonadotropin or beta HCG is used. In thyroid, it is thyroglobulin. In medullary thyroid or cells, it is calcitonin, which are obvious. Like we know that will be increased. And Like in some patients, the cytokeratin 18, CK18, or tissue specific antigen will be increased. And the other example is, pancreatic cancer and gastrointestinal cancer, CA19-9, which is being used. Like these are the examples that we use in daily life. Like if you go to a hospital, you can see that there are diagnostic methods for detecting the presence of CA19-9, carcinomembryonic antigen, alpha fetoprotein, beta HCG, thyroglobulin, calcitonin, cytokeratin 18, etc. And PSA, prostate specific antigen, which is tested in any lab. So these are the classical examples of tumor markers. There are n number of other tumor markers because these are very specific. These are very specific. That means that if a patient is having very high level of prostate specific antigen, invariably that patient is having prostate cancer. There is no other pathology which can increase prostate specific antigen. Okay. And similarly, like alpha fetoprotein, it means that either the patient is having hepatic cancer or the patient is having testicular cancer. There is no other way. Choriocarcinoma, if the patient is having very high level of beta HCG, it shows that the patient is having choriocarcinoma. So these are the things that is commonly used, which almost give a confirmatory test for cancer. There are other tumor markers which are used for prognosis or which are used to know the effectiveness of treatment, but they are less common. So the classification of tumor markers based on the chemistry can be like carbohydrate antigens, CA125, enzymes, prostate specific antigen, alkaline phosphatase, hormones and their metabolites, beta HCG, calcitonin, VMA. VMA ഏത് ക്യാൻസറിലായിരിക്കും? ആവണി.
Hello, sir.
VMA എന്താ? What is VMA? ഏത് ക്യാൻസറിലായിരിക്കും VMA ഇൻക്രീസ് ആവുന്ന? VMA ഏത് ഹോർമോണിന്റെ മെറ്റബോളൈറ്റാ? ഏത് ഹോർമോണിന്റെ മെറ്റബോളൈറ്റാണ്? Adrenal medulla. So pheochromocytoma is the cancer in which VMA can be increased. Serum protein. Thank you. Serum protein like immunoglobulin or Bence-Jones proteins can be increased. In which condition? Okay. In which condition we can see increased level of immunoglobulins? This one. Roll number 87. Harshana. Immunoglobulin കൂടുന്ന cancer ഏതാ? Or what you have already seen? Immunoglobulin കൂടുന്ന condition. Roll number 87. Harshana. Roll number 88 ഉണ്ടോ? Roll number 86. Okay, roll number 86 ആണോ? Roll number 86, 87, 88. Roll number 85. No, 84. Harikrishna.
Sir, I'm
87 പറഞ്ഞോ. ഇമ്മ്യൂണോഗ്ലോബുലിൻ കൂടുന്ന കണ്ടീഷൻ ഏതൊക്കെയാണ്?
ഏതാ സർ?
ഇമ്മ്യൂണോഗ്ലോബുലിൻ കൂടുന്ന കണ്ടീഷൻ ഏതാ? നമ്മൾ ഓൾറെഡി പഠിച്ചിട്ടുള്ളതാണ്.
മൾട്ടിപ്പിൾ മയലോമ.
മൾട്ടിപ്പിൾ മയലോമയാണ്. Like in which the immunoglobulin level will be very high. Even in Bence-Jones proteins, which it is seen in multiple myeloma, increased level. And there are something oncofetal products. because these are usually not seen in adult tissue, but these are seen in tumors because it resembles the fetal tissue. That's why it is called oncofetal products. Onco means cancer, fetal means fetus, like child or infant. So alpha fetoprotein, calcium embryonic antigen, etc. So these are the class. This is the classification of tumor markers based on their biochemistry, and you should be knowing what are the uses of tumor markers, what are prominent examples of tumor markers, and the biochemistry. So yeah, this is Albert Lasker and Mary Lasker. Albert Lasker was an he is known as father of modern advertising. The, like back then, even now, most of the things, even if it's political or social or branding, everything is used based on using advertisements, right? Because like advertisements have a major role in highlighting the issues, and he was the man who was behind the ad, like famous ads of very famous brands. Like he was behind. നിങ്ങൾക്ക് എത്ര പേർക്ക് അറിയാം like many of you may be knowing that soap opera കേട്ടിട്ടുണ്ടോ? നിങ്ങളിൽ ആരാ ജി കെ ഉള്ള ആരാന്ന് ആരെങ്കിലും കൂട്ടുകാർക്ക് ആർക്കെങ്കിലും ജി.കെ അറിയാമെങ്കിൽ ജസ്റ്റ് ഒന്ന് ചാറ്റിൽ ഒന്ന് കമന്റ് ചെയ്യാം. എമിലെ Emil, roll number 69. Roll number 69. Emil. Okay, whatever. Like soap opera, like soap opera was initially started as like serials was first started as a branding for soaps. Like Ivory soap എന്ന് പറയുന്ന soap ഉണ്ട്. Like അതിന്റെ ഒരു ബ്രാൻഡിങ്ങിന്റെ ഭാഗമായിട്ടാണ് like they started producing serials. So he was the man behind that also. So in 1950s and 1960s, what happened was that they were into social causes also, but this man died of cancer. Albert Lasker died of cancer, and his wife was so determined that they have to find treatment for cancer. Like in Second World War, if you know the history of political history, you must have studied about First World War and Second World War. And this First World War and Second World War had a prominent effect on medical field also. Like Second World War especially, we started getting patients like with umpty number of trauma. We had lacerated wound, incised wound, like organ damage, fractures, etc. Surgery and orthopedics had a major growth during that period because we need to fix it. We need treatment for fix it, and also antibiotics. If you know that penicillin was discovered in 1938. And it was maximally used during Second World War because we had n number of patients with wound infections, wounds, etc. So we started producing antibiotics, newer antibiotics, because penicillin was not enough. We started newer treatment for wounds, started newer treatment for organs. We studied more about anatomy because the patient, like most of the time, the wounded soldiers will be coming with entire things open. So we needed to operate in, we needed to know more anatomy. So we started learning about anatomy. We started learning about newer surgical procedures. We started studying about newer surgical tools and so on. So surgery field was very much developed by the end of Second World War. And this man died of cancer. So his wife was so determined that we need a treatment for cancer. And as I said in the beginning, the cancer was considered as a single entity. They didn't know that each cancer was different. And if you go through the novels or films of 50s and 60s and 70s, you can find that almost all protagonists will be having blood cancer. And they didn't even know that each blood cancer was different. What we study as AML, CML, ALL, CLL, etc. was not known then. They didn't know that Hodgkin's lymphoma was different from blood cancer. They thought that everything was same. So they started experimenting on treatment for blood cancers, because back then it was thought that blood cancer was mostly affecting children. So it was there was some emotional connect to it. So they started having development. They started developing treatment for blood cancer. They thought that every cancer was caused by some common entity, a common etiological agent. So if they found out a treatment for one cancer, they can use the same treatment for every cancer. So they started experimenting on it. They started they when they researched, they found out that there was some medicine that is commonly used which had the capacity to kill cells. One was radiotherapy, because in 1920s and 30s it was found out that, and after Hiroshima bombing, it was found out that the radiotherapy kills actively dividing cells. The actively dividing cells in our body is most common is bone marrow cells. So they started discovering that bone marrow cells was killed by radiotherapy. So they started giving radiotherapy to the patients. They started giving low dose, high dose, repeated dose, like whole body chemotherapy, whole body radiotherapy, targeted radiotherapy, and so on. And it was found out that in some patients it regressed, but in other patients it did not. So they found out that radiotherapy alone was not enough. Even if it was targeted, radiotherapy alone was not enough for controlling the cancer. So they started experimenting on chemotherapy. They wanted to discover a drug which can cure all cancers. And they started experimenting on it. They found out that there are some drugs which is given to control microbial, like bacterial infections, which have the capacity to kill cells. Though it is given as antibiotic, it has some property which kills actively dividing cells. They started experimenting on it. They started that it was antimetabolites, there are some antibiotics, there are some other chemicals which was discovered for other purposes, but they started using it for cancer treatment. They started experimenting on it. They found out similar chemicals. They give it in one dose. They combined two drugs. They combined three drugs. They combined four drugs. They gave it in repeated doses. They gave it for months, and at last found out that some combinations were effective. By that time, like this is a long process. The research is a long process, and imagine this is given for patients starting from a few months to 20s. As I said, blood cancer was the target, and blood cancer, whether it is AML or ALL, it affects mainly children or adolescent age group. So we were giving treatment after treatment for these patients. Some survived, some didn't. So they started experimenting on it, and after 1960s, they found out many drugs which can be used for cancer. They found out some regimen which can be used for treatment of cancer. They found out the classification of drugs which can be used for cancer. But at the same time, after 1970s, they also discovered one thing, that each cancer is different. Some need surgery, some need radiotherapy, some need chemotherapy, some need a combination of these. For example, breast cancer. Breast cancer, the treatment is that initially either we will be doing the surgery or it will be followed by chemotherapy plus radiation. Or it can be the other way around. Either the patient will be having chemoradiation first, we will reduce the tumor and do the surgery. So everything started with these two persons. And imagine the medical, like if you look at the history of medical science, it is not usually the medical doctors who are creating revolutions. It is the people outside the community. For example, one example is this. Like the second example that we studied in this class itself was regarding alpha fetoprotein. He was a plant biochemist. He was not at all he didn't have any medical degree, but he was a plant biochemist who discovered that alpha fetoprotein can be used as a tumor marker. And as I said, radiotherapy, it was during the uh, it was during the research of nuclear energy, like nuclear fission, fusion. They discovered that, and also in the research purpose for electron. ഇപ്പോൾ ഈ ലാർജ് ഹൈഡ്രോൺ കൊളൈഡർ ആണെങ്കിലും like electron, what do you say? Activating the electron requires large amount of energy. Like for that we discovered cyclotron. Cyclotron is an is an instrument which can be used to activate electron by giving focused high energy radiations. We discovered that it can be used for giving focused high energy radiation in the treatment of cancer also. Like that, we started step by step. We started researching on the treatment for cancer, and you must imagine that it was not even 50 years uh, since we discovered majority of the treatment that is given for cancer. Even 40 years, because many of the treatment, many of the regimen that we give today, like if you you must be like even in your anatomy text or physiology text, you'll be studying about different cancers, different classification of cancers. These different classification was discovered like very in the second half of 20th century. That means it was not long since we advanced on our medical science. Like whether it is chemotherapy, whether it is radiotherapy, whether it's surgery. Back then, as I said, surgery was considered. We didn't know about skip lesions. We didn't know about sentinel nodes. What is sentinel nodes? Ayana Joni. Sentinel node in the. Okay, Swati.
Hello, sir.
Sentinel node in the. നിങ്ങൾ അനാറ്റമിയിൽ പഠിക്കുന്നതാണ് സെന്റിനൽ നോഡ്. എവിടെ പഠിച്ചിരിക്കുന്ന സെന്റിനൽ നോഡ് അനാറ്റമിയിൽ? സോറി, ഗസ്റ്റ് ചെയ്താലും മതി.
Hello, sir.
പറഞ്ഞു.
Ayana.
അതിനെ പറഞ്ഞു മനസ്സിലായി.
Cancer cells spread in first lymph node, sir.
Yeah, cancer cells is spread in a first, like the first lymph node. It may not be the first lymph node, but these are the lymph nodes to which tumor spreads. Like anatomically, it is a continuous structure. So these are the lymph nodes to which the tumor drains, so that will also be like infect like it will also be containing tumor cells. So in surgery that should be removed. Back then we didn't know anything about sentinel node. What we do is that we remove entire nodes in the vicinity, but sentinel node will not be there. So we started researching on it. We found out that sentinel node is something different. We can dye it. We can inject a dye to tumor area. We can find whether to which lymph node it is draining. We can remove that lymph node. We can take a biopsy. We can know like something like PET scan to know whether the treatment is effective or not, and so on and so on. And also we can take CT or MRI to know the extent of cancer. Back then it was not that. It was only after opening that will be knowing whether the cancer is spread, there is metastasis to other organs, etc. or not. About initially, like what I want to convey is that initially we had exclusive drugs which acted in cell cycle. Cell cycle because, as I said in the beginning, our aim was a treatment for blood cancers. And blood cancers are actively dividing cells. So any therapy which was effective in blood cancer was the one which acted on cell cycle. Because these drugs acted in cell cycle, which effectively killed actively dividing cells, that is bone marrow cells. So any drug which act upon any of these stages of cell cycle, mostly it's S phase because DNA synthesis is happening in that phase. So almost all the chemotherapeutic agents were focused on S phase. It can be purine analogs, pyrimidine analogs, it can be antimetabolites, etc. Or it was mainly in G2 phase because or in M phase in which microtubules was there. So anti-microtubule agents were used and so on. So these are the examples of these are the examples of drugs which act on cell cycle. So it is aptly called cell cycle specific agents or cell cycle specific anti-neoplastic agents because it acted upon rapidly dividing cells. It acted upon in some stage of cell cycle, mostly S phase in which DNA synthesis is happening. Either it can be topoisomerase 1 inhibitors, topotecan, irinotecan, or it can be antimetabolites. Like it is mainly folate analogs. Synthesis of folic acid or active component of folic acid, that is tetrahydrofolic acid, is inhibited. And in a way, folic acid is not generated or synthesized. What happens is that folic acid is needed for DNA synthesis. It doesn't happen. DNA synthesis doesn't happen. It effectively means that cells will not be divided. Newer cells will not be formed. Or it can be purine analogs or pyrimidine analogs. Purine analogs like cladribine, fludarabine, mercaptopurine, pentostatin, thioguanine. Or it can be pyrimidine analogs, capecitabine, cytarabine, gemcitabine, floxuridine, and fluorouracil. നിങ്ങൾ പലപ്പോഴും 5FU എന്ന് കണ്ടിട്ടുണ്ടാവും, 5-fluorouracil, and many of the drugs will be familiar to you. Like these antimetabolites, especially for folate analogs, are important in your physiology also. Even in folic acid, in vitamin classes, we'll be discussing about it. Why folic acid is important. What are the medicines what are the antibiotics or antimetabolites which can inhibit folic acid synthesis, thereby inhibiting DNA synthesis, thereby inhibiting the cell division as such. Or it can be drugs acting on M phase, which are vinca alkaloids, vinblastine, vincristine, vinorelbine, or it can be taxane, again acting on microtubules, docetaxel and paclitaxel. So these are the drugs that is acting on cell cycle. But there are, as I said, initially the treatment was very much focused on blood cancer. So we were very much focused on cells which are actively dividing or drugs which are acting on cells which are actively dividing. But later it was found out that it need not be so. There can be other conditions. There can be other conditions in which tumor may not be actively divided. Or for regression of tumor, we need to add an agent which is not cell cycle specific. We started researching on it and found out certain drugs which can be cell cycle non-specific. One is alkylating agents. As the name suggests, it's an alkylating agent which transfers alkyl group to genetic material, thereby effectively causing the death of that cell. Example are cyclophosphamide, chlorambucil, ifosfamide, and busulfan. Or there can be platinum compounds which are causing cross-linking of DNA, cisplatin, carboplatin, and oxaliplatin. There can be some antibiotics, not the usually used one, but there are certain antibiotics which can be used for treatment of cancer. And as I said, the research on cancer went on. Like these are like, if you look at these drugs are not specific for a tumor, are not specific for a disease or a particular cells or something. It acts generally, but since it has some specificity, it can be used as a treatment for tumor or cancer. But later with studies, we found out that to have an effective treatment, we need to have a specific target. We need to target a particular surface antigen or some cell molecule in tumors so that only tumor cells are being killed, thereby decreasing side effects. Like if you look at cell cycle specific or cell cycle non-specific, most of these chemotherapeutic agents will be having very high side effects because it is not particular to tumor cells. It can act on normal cells as well. So we needed a targeted therapy which acts only on tumor cells, thereby decreasing side effects, like decreasing the length of the treatment, the treatment regimen can be improvised and so on. So they started having research for targeted drugs which acted specifically on tumor cells. One example is monoclonal antibodies. As you can know, antibodies are very specific. So if there is an antibody against some surface tumor antigen or surface antigen or tumor antigen, it can be very specific. So we started researching on it. One such example is trastuzumab. As you know, like MAB means this. MAB stands for monoclonal antibody. So if you found any drug with N with MAP, it shows that it is monoclonal antibody. There are certain MAP which is used or monoclonal antibodies which are used for treatment of COVID as well. You might be encountering it in newspapers. So trastuzumab was a monoclonal antibody which is used against HER2 receptor. So it is very specific and we can have a targeted therapy. Or it can be like therapeutic agents which can target specific enzyme or pathways. The classical example is imatinib. Imatinib is used to target BCR-ABL tyrosine kinase enzyme, which is very classic of CML. Chronic myeloid leukemia. In chronic myeloid leukemia, the classical etiology is the chromosomal anomaly, which results in the production of BCR-ABL tyrosine kinase. So, if there is a drug which inhibits BCR-ABL tyrosine kinase, we can have an effective treatment for CML. So, we started developing a drug which targeted BCR-ABL tyrosine kinase, thereby targeting the tumor cells in CML. So, tumor cells in a specific parameter, it can be like the product of tumor cells, but effectively the effect of tumor cells are being like we are being controlling it. So, classical example is imatinib. So, in a nutshell, antineoplastic therapy can be cell cycle specific, cell cycle non-specific. What do you mean by cell cycle specific? Because it acts on some phase of cell cycle. It is classically S phase in which DNA synthesis is happening, or it can be M phase in which mitosis or microtubule formation is happening. So S phase antineoplastic drugs can be divided into antimetabolites, topoisomerase inhibitor, antimetabolites again divided into folate analogs, purine analogs, pyrimidine analogs, and M phase acting drugs can be divided into taxanes or Winga alkaloids. G2 phase can be epipodophylotoxin or bleomycin, and G1 phase it can be hormonal drugs or antineoplastic enzyme, asparaginase or pegaspargase enzymes which acts on G1 phase, or it can be cell cycle non-specific, which indirectly mean that it acts on even normally dividing cells. It need not be rapidly dividing cells. It can act on normally dividing cells or normal cells also. It can be alkylating agents, it can be platinum compounds, it can be antibiotics. Then, as research progressed, we found out that we need to have targeted therapy which is very specific for cancer, which is minimal side effects, which have minimal dosage, which have minimal length of treatment regimen. So we started having targeted chemotherapy, and the classical example is monoclonal antibodies which targets tumor antigen or surface antigens. And one example is trastuzumab, which binds to HER2 receptor. Also, it can be compounds which have some specificity, which target some enzyme or pathways, which is very classical of that particular tumor. One such example is imatinib targeting BCR-ABL tyrosine kinase. BCR-ABL tyrosine kinase is the enzyme that is formed in CML. So if we target the enzyme, effect of CML can be reduced, or we can slowly, along with other treatments, we can push the CML into remission phase. And these are the this is about the biochemistry of cancer. Like in last class, we talked about We talked about epidemiology, mutagens, chemical mutagens, chemical carcinogens, anti-mutagens, and also oncogenic viruses. That I didn't tell. Okay. Uh, when cancer therapy was like when cancer research was going on for having a single therapy for cancer, what they found out that they found out about Epstein-Barr virus and Burkitt's lymphoma. As I said in the beginning, it was in 1960s they found out that some region in Africa were showing lymphoma. Lymphoma is a type of cancer. So they were having carcinoma, but the spread of that cancer was similar to that of a viral disease. They found out that Burkitt's lymphoma was caused by Epstein-Barr virus. It had an effect on cancer treatment also, because initially they were finding some therapy that targeted rapidly dividing cells. Then they thought that it was a virus that is causing cancer. They thought that every cancer was caused by some virus. So they started researching on virus behind every single cancer. Later they found out that it is not practically possible. They found out that Burkitt's lymphoma, if we give antiviral agents, it can be effective. But in other cases, it may not be effective. And most of the time, though the cancers are caused by viruses, once the cancer sets in, there is no use of antiviral agents. These are anti-neoplastic drugs that should be given in that patient also. There is no effective treatment by giving antiviral agents, and so on. So we studied about viral oncogenesis, how it is acting. This viral oncogenesis or the mechanism of virus is equally important for your next class, recombinant DNA technology. അപ്പോൾ അത് പഠിച്ചിട്ടിരിക്കുക. ആ സമയത്ത് ക്വസ്റ്റ്യൻ ചോദിക്കുമ്പോൾ അറിയില്ല എന്ന് പറഞ്ഞാൽ ശരിയാവില്ല. കാരണം we have discussed it in ELISA, sorry, not ELISA. We have discussed it in about like in viral oncogenesis we discussed it. We discussed it in RT-PCR. Yeah, in PCR we discussed it, and so on. There are growth factors. What are the mechanism behind oncogenes, oncosuppressor gene, and tumor markers and antineoplastic drugs. അപ്പോൾ ഇതൊന്ന് ഓർക്കുക. ഒരു കാര്യം കൂടി പറഞ്ഞിട്ട് നിർത്താം. Like as I said in the beginning, in 1940s, 50s, and 60s, they were behind a single drug for cancer. I said in the beginning, but they had another reason for having a project like that. One reason was that they didn't know that each cancer was different and etiological agents in each cancer was different. The another reason was that they needed a project which was very targeted. Like if you know some of the projects in other scientific fields, we can have an analogy. For example, in 1969, America sent astronauts to moon. Astronauts no പറയാൻ പറ്റില്ല, like man to moon. Space ലേക്ക് പോണവരെയാണ് astronauts എന്ന് പറയാ. Like if you can tell like astronauts to moon, even it's fine. And that project was having a single target. പലപ്പോഴും research purpose, North Indian students please mind. Like പലപ്പോഴും research purpose, either we can have a single target. അതായത് 1969 like 59 പ്രഖ്യാപിച്ചതാണ് 1970ക്ക് മുമ്പ് അമേരിക്ക ഒരാളെ മൂണിലേക്ക് അയക്കും. 59 പ്രഖ്യാപിച്ചതാണ്. Within 10 years, we will be sending a man to moon. So they had a target. So every research was towards achieving the target. They didn't know how to achieve the target, but every research was focusing on that. And similarly, they thought that if they have a focus like target like treatment for cancer and started having funds like billions of dollars into cancer research, into cancer chemotherapy, they can find out a single therapeutic drug which can cure all cancers. Though it was not successful, the cancer research had an exponential growth. What was till then that was a neglected field. Cancer was not actively you can't say that cancer was actively researched. As I said, it was due to the ad skills of this Lasker Foundation. They cancer was into public imagination. People were having an idea what cancer is, what a treatment of cancer is. They needed a treatment of cancer. Government should fund cancer treatment and so on. Back then, till then, they didn't mind about cancer because they had other diseases to worry about. So one is that the second research. അതും കൂടി പറയാനാണ്. അതായത് there are two ways of research. One is having a specific target. The second is not having specific target. Like they keep on researching, they find some like things in between, they connect it and find a treatment. So they started studying about cellular biochemistry, how the cell is acting, how cell is dividing, how cancer cell is what is the etiology of cancer, how cancer cells is different in each organ, how the etiology is different in each organ, what is the biochemistry, what are the biochemical markers it is producing, what are the different ways in which it is progressing. And they studied about all these, and they started finding the chemotherapeutic agents targeting each step. The classical example is targeted approach. They didn't study, they didn't first find imatinib and started using for CML. It was the other way around. They found out that in CML, it was the BCR ABL tyrosine kinase that is the factor which is causing the progression of CML. We need a treatment for that. But in the initial time, it was the other way around. We find some antimetabolites, we find methotrexate, we use it in patients. We found out that methotrexate is acting on rapidly dividing cells, so it can be used for cancer. It was the other way around, so it was very non-specific. The sad part is about side effects. And in 1960s, 70s, imagine these children with blood cancer were having experiments after experiments. Like experiment fail means they will die. Experiment successful means they will be like Snehamad or Anjuin. Experiment successful means that they will be having a good prognosis. But most of the time, this cancer will be relapsing. So they started experimenting again. And imagine the side effects of these medicines, the emotional trauma of these medicines, and n number of tests that is being conducted in these patients. Because it is being recorded that almost 600 tests, including lumbar puncture, bone marrow, like aspiration, blood test, is being conducted on a single patient. 600 tests spanning 1 or 2 years on a child. So, like researchers went on like that, and they found out various, like it was later that we found out that most of the treatment that we gave that time were not at all effective. So what I want to point out is that this is a continuous process. Sometimes research will be successful, sometimes it appears to be successful, sometimes it will not be successful in the first phase itself. So what like it's an ever learning procedure. That's what I should highlight. And thank you. Sneha madam joined there. Okay, I'm leaving. Thank you. Like if there's any doubt, you can contact.
Thank you, sir.
Thank you, sir.
Thank you.
Good morning, all.
Good morning, ma'am.
Biochemistry class is over, no?
Yes, ma'am.
Okay. So after a long time, no? കണ്ടിട്ട് ഒരുപാട് നാളായി അല്ലേ എല്ലാരും? എല്ലാവർക്കും സുഖമാണോ? ഞാൻ ആരാന്ന് മനസ്സിലായോ? ആരാ ക്ലാസ് എടുക്കുന്നതെന്ന് മനസ്സിലായോ?
Yes, ma'am.
ആരാ?
Sneha, ma'am.
ഓക്കെ. എന്റെ 71 പേരേ ഉള്ളോ? ബാക്കിയുള്ളവരൊക്കെ എവിടെ? ബാക്കിയുള്ളവരും എവിടെ പോയി? കുറച്ചു പേർക്ക് കയറാൻ പറ്റുള്ളോ? അങ്ങനെ വല്ലതും ഉണ്ടോ?
മാം ലിമിറ്റഡ് ആണ് മാം.
100 ആണോ? ഓക്കെ ഓക്കെ. എന്നാലും 71 പേരല്ലേ ഉള്ളൂ. 100 പേർക്ക് കയറാലോ.
അത് മിക്ക ദിവസം
അങ്ങനെ അയക്കും കേട്ടോ. കുഴപ്പമില്ല. നിങ്ങൾക്ക് ഒരു കാര്യം മനസ്സിലായില്ലേ? നമ്മൾ ഈ ക്ലാസ്സിൽ എടുക്കുന്ന കാര്യങ്ങളൊക്കെ ഇമ്പോർട്ടന്റ് ആണ്, നിങ്ങൾക്ക് എപ്പോഴും ചോദിക്കും എന്നൊക്കെ പറയുന്ന ആ പറഞ്ഞ സാധനങ്ങൾ അത്രയും നന്നായി പഠിച്ചിട്ടുണ്ടായിരുന്നെങ്കിൽ നിങ്ങൾക്ക് പരീക്ഷയ്ക്ക് അത്യാവശ്യം നല്ല മാർക്ക് കിട്ടുമായിരുന്നു എന്നുള്ള കാര്യം നിങ്ങൾക്ക് മനസ്സിലായില്ലേ? അപ്പൊ ഇനി നിങ്ങൾ തനിയെ തീരുമാനിച്ചോ കേട്ടോ, ക്ലാസ്സിൽ കയറണോ വേണ്ടോ എന്നൊക്കെ ഉള്ള കാര്യം. എന്തായാലും നമ്മൾ ഇന്ന് വി ആർ ഗോയിങ് ടു somebody's phone is unmute mode. Please, all of you, please mute your phone. So today we are going to start with a new topic. Actually, the topic is a very important topic. So before going into the topic, let me share a video with you. We'll watch a video. Are you all ready to watch the video? Are you all ready? Shall we watch the video?
Yes, ma'am.
Okay.
Yes, ma'am.
We'll start. Play ആവുന്നുണ്ടോ? ഇല്ല. അത് പക്ഷെ ഇന്നലെ പ്ലേ ആയിട്ടുണ്ടായിരുന്നു പറ്റിയിട്ടില്ല. യൂട്യൂബിൽ ഷെയർ ചെയ്യാം. Okay, okay. Just wait for a while. ഇവിടെ ഉണ്ടെന്ന് നോക്കാനായിട്ടുണ്ടെന്ന്. അല്ലേ? Just wait for a while. അതാണ് എന്റെ സംശയം. വേറെ ലിങ്കാന്ന് തോന്നുന്നു. ഓക്കെ. ഈ ഫയൽ ഡൗൺലോഡ് ചെയ്തിട്ടില്ല. നെറ്റ് ഉള്ളപ്പം ലിങ്കായിട്ട് ആഡ് ചെയ്തിരിക്കുന്നു. പക്ഷെ ഇന്നലെ എനിക്ക് പവർ പോയിന്റ് ആയപ്പോ പ്ലേ ആവുന്നുണ്ടായിരുന്നു. So sorry for the delay. That video is not playing. I am extremely sorry for that. Shall we continue with the class?
Yes.
I'll that share that link with you. Okay. Okay. So how many of you have seen drunken people? Have you ever seen drunken people? പാമ്പിനെ കണ്ടിട്ടുണ്ടോ? പാമ്പ് നമ്മൾ
Yes, ma'am.
മലയാളത്തിൽ പറയത്തില്ലേ? So have you ever thought why they walk like that? ആലോചിച്ച് നോക്കിയിട്ടുണ്ടോ? Have you ever thought why they are moving in a, like they are not in a walking in a proper way, no? All disoriented, I mean moving in very much clumsy manner. What is the reason for that? So some of you can unmute and say, have you ever thought?
Alcohol affects cerebellum.
Yes, very good. Alcohol affects cerebellum. So what is the function, or why you need cerebellum? Why you need cerebellum?
Maintenance of posture and balance.
Yes, maintains posture and balance. Okay, very good. So which are the brain systems which are very important in maintaining or which are important in producing movements, or which are the most important brain systems which are concerned with motor control? നിങ്ങൾ ഇത്രയും ദിവസം പഠിച്ചത് വെച്ചിട്ട് സെറിബെല്ലം ഒഴിച്ചു നിർത്തിയിട്ട് നിങ്ങൾ ഇത്രയും ദിവസം പഠിച്ചത് വെച്ചിട്ട് നിങ്ങൾക്ക് എന്താ മനസ്സിലായി? If you want to make a voluntary movement, which are the most important parts of your brain which are concerned for that?
Motor
You
cortex.
want to make a voluntary movement. So which all parts of your brain do you need? Yes, tell me.
Motor cortex.
Excellent. You need an intact motor cortex. Then what do you need? Then one more important structure you need, which is that. Yes. Have you studied about basal ganglia? Has it been taken? Basal ganglia?
Yes, ma'am.
Yes. So what is the function of the basal ganglia? And what is the function of the cerebellum? So one of you can unmute and tell me, how many of you love cooking? How many of you love cooking? Aishwarya MS? Aishwarya MS. Yes, Aishwarya, suppose you want to some guests are coming to your home and you want to make something. They have told you that they want something special to eat, and they told you that this item aanu avarku venda ennu parnu. So how will you proceed? What will you do? The next day they will be coming to your home. They have asked you to prepare something, but you are not quite sure about that. So what will you do?
At first, I will buy all the necessary items.
Yes, so you will, but you don't know how to, you don't know the recipe, no?
Yes, ma'am.
So what will you do? 10 people are coming.
Seek somebody's help.
Yes.
Seek somebody's help.
Yeah, you can ask for someone's help. Then they said you only make the dish. So what will you do?
YouTube videos.
Yeah. So based on that YouTube video, what will you do?
Mix the contents.
No, before mixing the contents, you will make a plan, no? So you will make a plan how to carry out this thing. You will go through the recipes. You will before starting the procedure, you will make a plan. You will find out the recipe. You will just note down what all things you should buy to make that curry, and then what will you do? Then you will buy all those things and you will make the curry or whatever dish it is, and then on the next day when they come, you will serve it to them, and then what will you do? When they have the food, what will you do? എന്ത് ചെയ്യും? അവർ ഫുഡ് കഴിച്ചു കഴിഞ്ഞിട്ട് നമ്മൾ എന്ത് ചെയ്യും? ഐശ്വര്യ
Yes, ma'am.
എന്ത് ചെയ്യും? ഐശ്വര്യ കഴിക്കുന്ന കണ്ടോണ്ടിരിക്കോ?
ഇല്ല, എങ്ങനെയുണ്ടെന്ന് ചോദിക്കും.
Yes, very good. You will ask for their feedback, no? So why you want their feedback? Why you want a feedback?
ചെയ്തതിന്റെ എഫിഷ്യൻസി അറിയണം.
Yes, very good. So you want to find out whether what you have prepared is the right thing or not, and if for the next time you can improve upon that. If there are some defects, you will be able to improve upon that, right? So this is how you will carry out any activities you want to make out. This is how you will carry it out. No, the same thing happens in our body also as far as the motor control is concerned. Is that clear for you? What I'm trying to convey you? Is that clear? So similarly, if your body wants to make a movement, there are 3 important systems which are concerned with the movement. I'll tell you. Is my screen visible to you? Is my screen visible to you?
Yes, ma'am.
Okay. So the video I couldn't play. I don't know what has happened. I'm sorry. So, is the screen visible right now?
No.
No, ma'am.
Something has happened. I'll just wait for a second. Wait for a second. So in your brain, meanwhile it get opened, I'll tell you the thing. So there are 3 important systems which are associated with motor control. They are, the first one is the motor cortex, which is the primary motor area. The primary motor area. Which is the primary motor area?
Area 4.
Area 4, very good. Okay, so one second. Now I'll share. This is all a mess, no? Why screen sharing is not possible? Screen sharing option is not being shown here. Oh. പറ്റുന്നില്ല സ്ക്രീൻ ഷെയറിങ് ഇതിനകത്ത് കാണിക്കുന്നില്ല സ്ക്രീൻ ഷെയറിങ് ഇതോ ഷെയർ ഓക്കെ താങ്ക് യു. Is anything visible right now? Is anything visible now?
Ma'am, started sharing എന്ന് കാണിക്കുന്നു.
Okay.
മാം ഇപ്പൊ വന്നു.
Okay. I'm sorry for all the mess that has happened. I don't know what has exactly happened. So today, let me start everything once again. So we are going to study about the cerebellum. So as you all know, there are three most important systems which are concerned with motor control. As I have told you, the motor cortex, cerebellum, and the basal ganglia. So in today's session, what we are going to study is, I'll just briefly tell you about the functional anatomy of the cerebellum. And then we will go into the functional classification of cerebellum. It's extremely important for you how the cerebellum is functionally classified. And then I'll tell you about the cerebellar cortex and its layers. Then we will talk about the cerebellar nuclei. Then we will see the microcircuit present in the cerebellum, okay, or the intrinsic fibers present within the cerebellum. And then I'll tell you about the afferent connections and the efferent connections of the cerebellum. The remaining portions, that is the function of the cerebellum and the diseases of the cerebellum, will be taken in the next class. So these are the things that we'll be studying today. Okay. So as you can see here, so this is how a movement is brought about. When you think of making a movement, that plan is, or that idea will be, it will be processed in the cortical association area, and that will undergo also similar kind of, that plan will be sent to the basal ganglia and the lateral cerebellum. Is that clear for you? So when you want to make, if I ask you to write something, if you want to make that writing movement, that planning of that movement happens in three important areas. One is the cortical association area, basal ganglia, and the lateral cerebellum. Then what they will do, they will give commands to the premotor and the motor cortex. So from the premotor and the motor cortex, which pathway will initiate the movement, or which pathway will execute the movement? ഏത് പാത്വേ ആണ് മൂവ്മെന്റ് തുടങ്ങുന്നത്? ഏതാ? എവിടം വഴിയാണ് ആ ഇൻപുട്ട് വരുന്നത്? നിങ്ങൾ പ്ലാൻ ഉണ്ടാക്കി, പ്ലാനിന് ശേഷം മൂവ്മെന്റ് നടത്തണം അല്ലെ? അതല്ലേ നിങ്ങൾക്ക് വേണ്ടത്. ഞാൻ നിങ്ങളോടൊരു കാര്യം എഴുതാൻ പറയുമ്പോൾ നിങ്ങളുടെ മീൻസ് നിങ്ങൾ അറിയാതെ തന്നെ നിങ്ങളുടെ ബ്രെയിനിന്റെ ഉള്ളില് ആദ്യം അതിന്റെ പ്ലാനിങ് ആണ് നടക്കുന്നത്. അതിനുശേഷമാണ് ആ മൂവ്മെന്റ് ഉണ്ടാവുന്നത്. സോ ദ പ്ലാനിങ് ഹാപ്പൻസ് ഇൻ ദ കോർട്ടിക്കൽ അസോസിയേഷൻ ഏരിയ, basal ganglia, and the cerebellum, as you can see here. And that plan will be taken up by the premotor and the motor cortex, which will carry it out as the movement. So what has happened here? Here what has happened? The next portion. The next portion, you look at the next portion. One second. So here what has happened? Look at this portion and tell me what is happening here. Aishwarya, evide endha nadakune? Then what is this? Your movement has happened. Then yes, movement has occurred. Then this is the feedback. Understood? That is also very, very important. Suppose you are trying to throw a stone onto a mango. Suppose if your movement is not in a correct way, will that mango fall? Video. Illa. So every time when you are making the movement, whether that movement is in the correct manner or not, so to make corrective movement or to make corrections, this intermediate cerebellum. So I'll tell you what is lateral and intermediate cerebellum. So it will give feedback comments, so that you can make the movement more perfect. So this is how a movement is carried out in your body. This is very, 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 very important. So you should be very, very thorough with this. നിങ്ങൾക്കൊരു മൂവ്മെന്റ് ഉണ്ടാക്കണമെങ്കിൽ your cortex alone, your motor cortex alone can't make that movement. You need the coordination of basal ganglia, cortex, and the cerebellum to make the plan and execute the movement. So that is the importance of the cerebellum. So cerebellum as such cannot initiate a movement. The movement is mainly initiated by the cortex, but the feedback and the corrective, that planning, feedback, correction, then the smoothening of movement, everything happens or it occurs together with the help of the cerebellum along with the basal ganglia and the cortex. Is that clear? Is that clear? Shall we move to the next slide? Is that clear
ma'am.
for all? Okay. So now we will go to the functional anatomy of the cerebellum. So you can see here, this is the cerebrum and this is the brain stem. So this is the pons and this is the, below the pons, what is the structure? This is the
Medulla.
medulla. And you can see that the cerebellum is located posterior to the brain stem. Okay, and it is situated in which cranial fossa? Which cranial fossa? How many cranial fossa are there?
Posterior cranial fossa.
Yes, it is the largest structure in the posterior cranial fossa. And you can see here something here. What is that? Between the brainstem and the cerebellum, what is this? What is this?
Pedangles.
Yes?
Fourth ventricle.
Yes, excellent. That is the fourth ventricle. Understood? So it's the largest part of the hindbrain. It occupies the posterior cranial fossa. It lies dorsal to the pons and medulla, and it is separated from these structures by, this is what? This is the fourth ventricle. Is that clear? Is that clear? Manasilayo?
Yes.
Yes, ma'am.
Okay. And now I'll tell you. So what are
Yes,
how this? Yes. Okay. So how the cerebellum is connected to other parts of the brain areas. Okay. So it is connected to the brainstem by 3 cerebellar peduncles. So the details of cerebellar peduncles you will study in the anatomy classes. I'll just briefly tell you the names of the peduncles. So the first one is the superior or the brachium conjunctivum, which connects the cerebellum to the, which is this structure above the pons.
Midbrain.
Cerebellum fibers. Cerebellum fibers, it is connecting it to the midbrain. So the superior cerebellar peduncle or the brachium conjunctivum connects the cerebellum to the midbrain. Is that clear? And next is the middle cerebellar peduncle. You can see here. Here is it. It is also called as a brachium pondus. What is it called as? It is called as a brachium pondus that connects the cerebellum to the pons. Clear? It connects the cerebellum to the pons. And the inferior one, which is also called as the restiform body. Can you see here? This is the restiform body or the inferior peduncle, which connects the cerebellum to the medulla. Is that clear? So you understand that the cerebellum is connected to the brainstem by 3 cerebellar peduncles, which are they? The superior peduncle connecting the cerebellum to the
Midbrain.
midbrain. Middle to brachium pondus to
Pons.
pons. Very good. The restiform body or the inferior peduncle connects the cerebellum to the medulla. So is that clear?
Yes,
Is
ma'am.
it clear? Okay. So shall we move to the next slide?
Yes, ma'am.
Yes, ma'am.
Okay. So anatomically, you can classify cerebellum into the anterior lobe, posterior lobe, and the flocculonodular lobe. But we are mainly concerned with the functional division of the cerebellum. Clear? How you can divide the cerebellum functionally based on the function. How can you divide the cerebellum? So this is very important for you from the exam point of view. So please mark it as an important topic. So functional division of the cerebellum. So based on the function, you can divide cerebellum into flocculonodular lobe or vestibulocerebellum. It is also called as the archicerebellum. Clear? Next is the spinocerebellum or the paliocerebellum. And the third is the cerebrocerebellum or the neocerebellum. So that is how you will classify or you will divide cerebellum functionally. You'll be studying about the anatomical division of cerebellum in the anatomy classes, but for us it is a functional division which is very, very important. So functionally you can divide them into flocculonodular lobe or vestibulocerebellum, which is also called as the archicerebellum. Please take down these notes because it is very, 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 very important. And the second is the spinocerebellum or the paliocerebellum, and the third is the cerebrocerebellum or the neocerebellum. Neocerebellum. Neo means what? What is the meaning of neo? Neo means new. Okay, so shall we look into each of them? Okay, നമുക്ക് ഓരോന്നോരോന്നായിട്ട് നോക്കാം. First is the vestibulocerebellum. What's the other name for that? You call it as a flocculonodular lobe. So you can you see here? Can you see here? This is the flocculonodular lobe. കാണുന്നുണ്ടോ? മനസ്സിലാവുന്നുണ്ടോ ഞാൻ പറയുന്നത്? This is the flocculonodular lobe and the median portion of the some part of the vermis also. Is that clear? Is that clear?
Yes,
Vestibulocerebellum or the flocculonodular lobe. This thing is the flocculonodular lobe. So from the name itself, it is very, very evident. No? So this part of the cerebellum will be intimately connected with എന്താണ് പേരിനകത്ത് ഇരിപ്പില്ലേ? Vestibulocerebellum. Vestibular apparatus. So you tell me what will be the function of that portion? Vestibulocerebellum or the archicerebellum or the flocculonodular lobe. What will be its function mainly? എന്തായിരിക്കും അതിന്റെ function? Yes, very good. Maintaining posture and equilibrium. Okay, so it is phylogenetically the oldest part of the cerebellum, which is also, so that is why it is also called as the archicerebellum. It consists of nodulus. This is the nodulus in the vermis. This median portion is called as the, this median portion of the cerebellum is called as the, നിങ്ങൾ anatomy പഠിച്ചതല്ലേ ഇതൊക്കെ? Anatomy ആയോ? ഇല്ലേ? Anatomy ആയില്ലേ? Dissection ആയില്ലേ? Cerebellum ആയി. അപ്പൊ ഈ സാധനം എന്താണ്? This is called as the vermis, median vermis. Okay, this portion is called as the nodulus. Okay, so the nodulus in the vermis and the flanking flocculus on the either side, they together forms the flocculonodular lobe. And so function എഴുതിയിട്ടില്ല അല്ലെ? So the function I have told you, it is mainly concerned with balance or the equilibrium, and balance and equilibrium, and also it is associate, it is ഞാൻ functions പറയുമ്പോൾ ഒന്നും കൂടി മീൻസ് നന്നായിട്ട് പറയാം. ഇപ്പൊ തൽക്കാലം നിങ്ങൾ അറിഞ്ഞിരിക്കുക. This is basically the function of the vestibulocerebellum is to maintain the posture and equilibrium, and also to make or coordinate the eye movements along with the posture maintenance. Clear? Clear? Is that clear? Is that clear? You കേൾക്കുന്നില്ലേ? Okay.
Yes, ma'am.
Okay. Now comes the spinocerebellum. So as you can see here, this portion, can you see here? This portion, this ഈ കാണുന്ന ഭാഗം. So this portion, the adjacent area, clear? This is the vermis, the median vermis, plus the adjacent portions of the cerebellar hemispheres. These are the cerebellar hemispheres. ഈ കാണുന്നതുമാണ് എന്ത്? Cerebellar hemispheres. So the median vermis plus the adjacent portions of the cerebellar hemispheres forms the spinocerebellum. And you can see that the median, the vermal portion, it descends or it forms the medial descending system. മനസ്സിലായോ? മനസ്സിലാവുന്നുണ്ടോ? കേൾക്കുന്നുണ്ടോ?
Yes, ma'am.
Okay. And the adjacent portions of the cerebellar cortex, the portions adjacent to the vermis, they project as the lateral descending system. So whatever it is mainly concerned with motor execution or motor, that the movement part is mainly carried out by the spinocerebellum. So it is formed by the rest of the vermis, that this vermis except the nodulus and the adjacent portions of the lateral hemisphere. Is that clear? So it is mainly concerned with execution of motor activity. Is that clear? Clear ആണോ? സംശയം ഉണ്ടോ ഈ പറഞ്ഞ? Okay. So now comes the, which is the third portion? Third functional division is neocerebellum or the cerebrocerebellum or the corticocerebellum. നിങ്ങൾക്ക് ഇപ്പൊ കേൾക്കുമ്പോ ഭയങ്കര എന്താ പറയണ്ടേ, ഒന്നിലെ ചിലപ്പോ ഭയങ്കര ഇതൊക്കെയാണോ വലിയ കാര്യം എന്ന് തോന്നും. ഇതൊക്കെ പരീക്ഷയ്ക്ക് ചോദിക്കുമ്പോ ഇതൊന്നും എഴുതിയിട്ടില്ലെങ്കിൽ വലിയ മുട്ട ഇട്ട് വെക്കും പേപ്പറിനകത്ത് കേട്ടോ. നിങ്ങൾ അപ്പൊ വന്നിട്ട് അയ്യോ മാർക്ക് കിട്ടിയില്ലല്ലോ എന്നൊന്നും പറഞ്ഞിട്ട് കാര്യമില്ല. ഈ പറയുന്ന കാര്യങ്ങൾ ശ്രദ്ധിച്ചിരുന്ന് കേൾക്കണം. ബിക്കോസ് കുറച്ച് കഴിയുമ്പോൾ ഇതെല്ലാം മറന്നു പോകും. ഇറ്റ് ഇസ് എ വെരി ഡിഫിക്കൽട്ട് ടോപ്പിക്. സോ യു ജസ്റ്റ് ലിസൺ ടു ദാറ്റ്. Okay, so cerebrocerebellum, or also called as a neocerebellum or the corticocerebellum, and it is phylogenetically the newest, and it is formed by the lateral portions of the cerebellar hemispheres. So you can see here, ഈ ഭാഗം, ഈ കാണുന്ന ഭാഗം കണ്ടോ, ഇത് cerebellar hemispheres ന്റെ lateral portion, ഈ ഭാഗവും മനസ്സിലായോ? ഈ രണ്ട് lateral portions, they are called as the neocerebellum or the corticocerebellum or the cerebrocerebellum. So what is its function? It interacts with the motor cortex. I have shown you a picture in the beginning and I've told you what is the role of cerebellum in planning the movement. Okay, so I've told you what is the importance of planning a movement. So this portion, this corticocerebellum, it interacts with the motor cortex in planning and programming of sequential motor movements. When you are, like, suppose if you are jumping, if you are doing some high jump or long jump or something like that, when you are about to jump, some of your muscles contract. At the same time, the antagonistic muscles will relax. And when you are about to land, some other group of muscles will contract and their antagonist will relax. So is all those things happening by your, are you voluntarily controlling it? Is it happening at the level of your consciousness? No, subconsciously you are doing that, അല്ലെ? ഇങ്ങനെ ചെയ്യുമ്പോ, ഇങ്ങനെ കാലെടുത്ത് നമ്മൾ ഹൈ ജമ്പിൽ ചാടുമ്പോൾ നമ്മുടെ ഇന്ന മസിൽ ഇങ്ങനെ കൺട്രാക്ട് ചെയ്യണം, അടുത്ത താഴോട്ട് വരാൻ നേരത്തെ അടുത്ത സെറ്റ് കൺട്രാക്ട് ചെയ്യണം എന്ന് ആരാ നമുക്ക് പറഞ്ഞു തരുന്നത്? ആരും പറഞ്ഞു തരുന്നില്ല. ആ സീക്വൻഷ്യൽ മോട്ടോർ മൂവ്മെന്റ്സ് എങ്ങനെ ഉണ്ടാവണം എന്നുള്ളത് that has already been planned and programmed. So who all are involved in planning and programming? It is the basal ganglia, it is the cerebellum. Which portion of the cerebellum? Which portion of neocerebellum? Understood. Along with the motor cortex, that motor association areas. They will make the plan and they will give the command to the motor cortex, primary and the premotor area, and they will bring about the movement, so that you will get a smooth coordinated movement. Is that clear? Is that clear for all of you? The functions we will be discussing later. Is that concept clear for you? Yes. How will you functionally divide the cerebellum? So what all things we have seen so far? I have told you about the gross anatomy, just briefly gone through the anatomy, and then we have covered the functional anatomy or functional classification of the cerebellum. Is this much thing clear for all of you? Is it clear for all of you?
Yes, ma'am.
Okay. Now, just like your sensory homunculus and the motor homunculus, you can see the topographical representation of your body in the cerebellar cortex. So I'll call out one name. So Atulya. വിളിച്ചിട്ട് കേൾക്കാത്തവർക്ക് ഞാൻ ആബ്സെന്റ് ഇടുവേ. Atulya Rose.
Yes, ma'am.
Atulya, just look at this picture and tell me how the body is represented topographically. What is the topographical representation of your body in the cerebellum? How is it represented in the cerebellum? Just look at the picture and tell me. അറിയാമോ? ഇല്ലെങ്കിൽ പറഞ്ഞു, അറിയത്തില്ലെന്ന് പറഞ്ഞു അത്രേ ഉള്ളൂ. Can you tell? Can you explain it?
അറിയില്ല ma'am.
Okay, who can do that? Is there anyone who can do that? Is anyone ready to explain it? Alamin?
അറിയില്ല മാം.
നോക്ക്, പടം നോക്ക്. Just look at the picture. Akash.
മാം നേരെയാണ്.
ആ പടം നോക്ക്.
ആക്സിയൽ പോർഷൻസ് വെർമിസിലും.
Very good. Excellent. Yes. Then the limbs and the distal portions, they are represented in the
lateral aspect.
Not lateral, just lateral to the median vermis. Vermisന് തൊട്ടടുത്തുള്ള ഭാഗങ്ങളിലാണ് the distal limbs and the distal portions are represented. In the corticocerebellum, that is in the lateral cerebellar hemisphere, there is no topographical representation. Topographical representation is present in the median vermis and the adjacent cerebellar hemispheres. And you can see that the medial portion, the axial portion of the body is represented in the vermis. The axial portion is represented in the vermis, and the distal limbs and the distal portions are represented in the intermediate zone, or the portion which is adjacent to the vermis. Is that clear? Is that clear for all of you? Is that clear?
Yes, ma'am.
Okay. So the axial portions of the body is represented in the vermis. The limb and the facial regions are represented in the adjacent cerebellar hemispheres. And the lateral portion of the cerebellum, there is no representation of the body parts. Is that clear? Okay. So now, so we have seen the anatomy, the functional classification of the cerebellum, and I've told you about the topographical representation of your body in the cerebellum. Now we are going to another important topic, that is the organization of the cerebellar cortex. So as you all know, your cerebral cortex, the outer cerebral outer portion is it gray or white? Is it gray or white? Gray. Why? Because it all contains
Cell body.
Excellent. Whereas the inner portion, interior to that, or just below that, it is all
Axons.
It is all axons or fibers, nerve fibers. So it is in which color?
White.
It is in white color. Excellent. Very good. So just like that, the cerebellar cortex is also, it is made up of outer gray matter and inner white matter. And the cerebellar cortex is extensively folded. And you call that fold as? എന്താ വിളിക്കുന്നത്? അനാറ്റമി പഠിച്ചതല്ലേ? You call it as para. You call it as folium. So the cerebellum weighs only 10% as the cerebral cortex, but the surface area, your brain in the cerebral cortex, suppose if it is 1 kg, അതിന്റെ 10 മാത്രമേ ആർക്ക് വെയിറ്റ് ഉള്ളൂ, സെറിബെല്ലത്തിന് വെയിറ്റ് ഉള്ളൂ. പക്ഷെ അതിന്റെ സർഫസ് ഏരിയ നമ്മൾ നോക്കുകയാണെങ്കിൽ ഇറ്റ് ഇസ് 75% ഓഫ് ദ സർഫസ് ഏരിയ ഓഫ് ദ സെറിബ്രൽ കോർട്ടെക്സ്. Why? Because the surface of the cerebellar cortex is extensively folded. It is extensively folded. You can see here, മടങ്ങിയാണ് ഇരിക്കുന്നത് അല്ലെ. അതുകൊണ്ട് അതിന്റെ സർഫസ് ഏരിയ ഭയങ്കര കൂടുതലായിരിക്കും. Is that clear? Is that clear?
Yes.
Okay. Now I will tell you about the organization of this, not the cerebellum, organization of the cerebellar cortex. Organization of the cerebellar cortex. ഇത് എഴുതി വെക്കണം. ഇത് നിങ്ങൾ കുറച്ച് കഴിയുമ്പോൾ മറന്നു പോകും. This is very, 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 very important. So the cerebellar cortex. So how many layers are there for your cerebral cortex?
6.
How many layers are there for your cerebral cortex? 6 layers. Very good. Most of your cerebral cortex is made up of 6 layers. That we call it as neocortex, right? How many layers are there? How many layers are there? Is it visible what I'm writing down in the is, and range is very low. Okay, extra layers under. So for the cerebellum, you have only 3 layers. So which are they? The upper one is this is the molecular layer, and the next layer is the Purkinje cell layer, and below that you have the granule cell layer. So the cerebellar cortex is made up of 3 layers. Which are they? Molecular layer, the upper one, and then you have the Purkinje cell layer, and below that you have the granule cell layer or granular cell layer. Granular layer. Clear? Molecular layer, Purkinje layer, and the granular layer. So this is very, 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 very important. മനസ്സിലായോ ഈ പറഞ്ഞത്? So cerebellar cortex ന് എത്ര ലെയറുകൾ ഉണ്ട്? Cerebellar cortex ന് എത്ര ലെയർ ഉണ്ട്?
3.
കേക്കുന്നില്ല. 3 layers ഉണ്ട്. Which are they? Which are they? Molecular layer, Purkinje cell layer, and then granular cell layer. അപ്പൊ നിങ്ങൾ തന്നെ പറ, എന്തുകൊണ്ടായിരിക്കും ഈ കോർട്ടെക്സ് ഉണ്ടാക്കിയിരിക്കുന്നത്, ഈ ഔട്ടർ ലെയർ ഉണ്ടാക്കിയിരിക്കുന്നത് എന്തുകൊണ്ടായിരിക്കും? ഈ ലെയേഴ്സ് ഒക്കെ ഉണ്ടാക്കിയിരിക്കുന്നത് എന്തുകൊണ്ടാ? മീൻസ് എന്ത് വെച്ചിട്ടാ ഉണ്ടാക്കിയിരിക്കുന്നത്? They are all made up of
Neurons.
Cell bodies.
neurons. Neuronal cell bodies. So you have different types of neurons in the cerebellar cortex. അത് ഏതൊക്കെയാണെന്ന് നമുക്ക് നോക്കാം. Which are the different types of neurons in the cerebellar cortex? You have 5 types of neurons in the cerebellar cortex. They are, the first one is the Purkinje cell. And what is the importance of the Purkinje cell? It is the largest of the neurons. Okay, and Purkinje cells, then you have the granule cells, then you have the basket cells, then the stellate cells, and the Golgi cells. Perella ezhuthi edutho. Purkinje cells, granule cells, basket cells, stellate cells, Golgi cells. Of these, the basket cells, stellate cells, and Golgi cells are inhibitory interneurons. ഇനി അങ്ങോട്ട് തിങ്സ് ഭയങ്കര കോംപ്ലിക്കേറ്റഡ് ആയി വരികയാണ്. നിങ്ങൾ ഇത് അടുക്കിനും ചിട്ടയ്ക്കും ഓർത്തിരുന്നിട്ടില്ലെങ്കിൽ ഇതെല്ലാം ഭയങ്കര ബുദ്ധിമുട്ടായിരിക്കും. അപ്പൊ നല്ല വൃത്തിയായിട്ട് പറയുന്ന കാര്യങ്ങൾ ക്ലിയർ ആയിട്ട് എഴുതി വെക്കുക. So how many layers are there for the cerebellar cortex? How many layers are there? You have 3 layers for the cerebellar cortex, and this cell layers, they are made up of different types of cells. Which are the different types of cells seen in the cerebellar cortex? Which are the different types of cells in the cerebellar cortex? They are Purkinje cells, granule cells, basket cells, stellate cells,
Golgi
and
cell.
Golgi cells. Golgi cells. Of this, the basket cells, stellate cells, and Golgi cells are inhibitory in the neuron. So which neurotransmitter they will be producing? Which neurotransmitter will they be producing? Name one inhibitory neurotransmitter.
GABA.
Yes. You have GABA and glycine. Here it is the GABA, which is the neurotransmitter. So we'll look into the molecular layer first. So you can see here the molecular layer. This elam pacha color is molecular layer. And which are the cells present in the molecular layer? ഇവിടെ നോക്കിയിട്ട് എളുപ്പം പറഞ്ഞേ ഏതാ മോളിക്കുലാർ ലെയറിലുള്ള സെൽസ്? നമ്മൾ ഈ പറഞ്ഞ 5 സെല്ലുകളില് ഏതൊക്കെ സെല്ലാണ് മോളിക്കുലാർ ലെയറിൽ കാണുന്നത്? എളുപ്പം പറയൂ, എളുപ്പം പറ.
Basket and stellate.
Excellent. You have the basket cells and the stellate cells. ഏതൊക്കെ സെൽസ് ആ ഉള്ളത്? You have the basket cells and the stellate cells. So and also you can see that there are the dendrites of the Purkinje cells and the axons of the granule cells. They are ending at the level of the molecular layer. Okay, so the cell types which are present in the molecular layer are the basket cells and the stellate cells, and also it contains the dendrites of the Purkinje cells, the axons of the granule cells, and the climbing fibers. You just forget about climbing fibers. I will tell you what is climbing fiber. Clear? Clear? മനസ്സിലായോ പറഞ്ഞത്? മോളിക്കുലാർ ലെയർ. ഇപ്പൊ നമ്മൾ ആദ്യം 3 ലെയർ ഉണ്ടെന്ന് പറഞ്ഞു. ഈ 3 ലെയറും ഉണ്ടാക്കിയിരിക്കുന്ന സെല്ലുകൾ ഏതൊക്കെ കൊണ്ടാണ് ഉണ്ടാക്കിയിരിക്കുന്നതെന്ന് പറഞ്ഞു. എന്നിട്ട് നമ്മൾ ഓരോ ലെയറിനെ പറ്റി പറയുകയാണ്. ഓരോ ലെയറിലും ഉള്ള സെൽ ടൈപ്പ്. അപ്പൊ ആദ്യം പറഞ്ഞത് മോളിക്കുലാർ ലെയറിനെ പറ്റിയാണ്. അവിടെയുള്ള സെൽ ഏതാണ്? ഇറ്റ് ഇസ് ദ ബാസ്കറ്റ് സെൽ ആൻഡ് ദ stellate cell, and also it receives the nerve endings like the dendrites of the Purkinje cells, axons of the granule cells, and the climbing fibers. ഇത്രയും പറഞ്ഞത് ക്ലിയർ ആണോ? ഇത്രയും പറഞ്ഞത് ക്ലിയർ ആണോ? ക്ലിയർ ആണോ?
Yes, ma'am.
Okay. So which is the next layer? I'll just briefly tell you about the basket cell and the stellate cell. The basket cell, why is it called as a basket? എന്തുകൊണ്ടാണ് basket എന്ന് വിളിക്കുന്നത്? Because they have short axons, and you can see that these are the basket cells present in the molecular layer. Their axons, they will form a basket like structure around the Purkinje cell. It will form a basket. It is called as the basket cell. Is it stimulatory or inhibitory? Is it stimulatory or inhibitory? Basket cell is stimulatory. They are inhibitory. They are inhibitory. They are stimulated by parallel fibers. I'll tell you what is parallel fiber. That they are stimulated by parallel fibers, but when they are stimulated, they will cause inhibition of which cell? Inhibition of which cell? Yes, very good. They will cause inhibition of Purkinje cell. നമ്മൾ ചില മനുഷ്യരെ കണ്ടിട്ടില്ലേ? ചിലർക്ക് ഭയങ്കര നല്ല രീതിയിൽ ആയി കഴിയുമ്പോഴത്തേക്ക് അവരെന്ത് ചെയ്യും? അവർ ബാക്കിയുള്ളവരൊക്കെ ഇൻഹിബിറ്റ് ചെയ്യും. അതേപോലെയാണ് ആര്? ബാസ്കറ്റ് സെല്ല്. ബാസ്കറ്റ് സെല്ലിനെ ആരാ സ്റ്റിമുലേറ്റ് ചെയ്യുന്നത്? They are stimulated by parallel fibers. I'll tell you what is parallel fiber. So they are stimulated by parallel fibers, but when they are stimulated, they will cause, their axons will cause inhibition of the Purkinje cell. Understood? So that basically causes lateral inhibition of the adjacent Purkinje cells, and that what is the importance of that? What is the synaptic inhibition? What is the importance of lateral inhibition? It helps to sharpen the signal. Signal നമ്മൾ ഈ ഒരു ന്യൂറോൺസ് വഴി പോകുന്ന സിഗ്നൽസ് സൈഡ് വേ സ്പ്രെഡ് ചെയ്ത് പോവാതിരിക്കാൻ വേണ്ടിയിട്ട് അത് സഹായിക്കും. So this is called as the feed forward inhibition. Stimulation leading to inhibition. Understood? Feed forward inhibition. Is that clear? Is that clear? Clear or no?
Yes, ma'am.
Okay, I know it is a highly complicated thing. ഇത് നിങ്ങൾ ശ്രദ്ധിച്ച് കേട്ടിരുന്നാലേ നിങ്ങൾക്ക് പക്ഷെ നല്ല ശ്രദ്ധിച്ചിരുന്നു കഴിഞ്ഞിട്ട് അടുക്കിനും ചിട്ടയ്ക്കും മനസ്സിലാക്കി it will be very easy for you. And the neurotransmitter involved here is GABA. Then I'll tell you what is stellate cell. Stellate cell, they are similar to basket cell, but they are more superficial. You can see here, they are superficial, and they also receive inputs from parallel fibers. Actually, you can parallel fiber, this fibers parallel fiber എന്ന് പറയുന്നത് കണ്ടോ പാരലൽ ആയിട്ട് പോകുന്ന കുറെ ഫൈബറുകൾ ഉണ്ട് ഇത് എവിടുന്നാ വന്നിരിക്കുന്നത് ഏത് സെല്ലിനാ വന്നിരിക്കുന്നത് ആ പടത്തിൽ നോക്കിക്കേ എവിടുന്നാ വന്നിരിക്കുന്നത് ഈ പാരലൽ ഫൈബേഴ്സ് പറ അയ്യോ പറ എവിടുന്നാ വന്നിരിക്കുന്ന പാരലൽ ഫൈബേഴ്സ് ആ പടം നോക്ക് കളർ
granule.
Yes, very good. They are the axons of the granule cells. മനസ്സിലാവുണ്ടോ പറഞ്ഞത് മനസ്സിലായോ അപ്പൊ ഏറ്റവും താഴെ കിടക്കുന്ന ഗ്രാന്യൂൾ സെൽസിന്റെ ആക്സോൺസ് ഏറ്റവും മുകളില് പാരലൽ ഫൈബേഴ്സ് ആയിട്ട് വരും എന്നിട്ട് അവർ ആരെയൊക്കെ സ്റ്റിമുലേറ്റ് ചെയ്യും പാരലൽ ഫൈബേഴ്സ് ആരെയൊക്കെ സ്റ്റിമുലേറ്റ് ചെയ്യും മോളിക്കുലർ ലെയറിൽ വന്നിട്ട് ആരെയൊക്കെ സ്റ്റിമുലേറ്റ് ചെയ്യും പറ they will stimulate the basket cell and the stellate cell പക്ഷേ ഈ basket cell ഉം stellate cell ഉം എന്ത് ചെയ്യും stimulated ആയി കഴിയുമ്പോൾ
Inhibit Purkinje.
Yes, is that concept clear for you? Important ആണ് പിന്നെ പറയരുത് ഞാൻ പറഞ്ഞില്ല എന്ന് their axons end on the Purkinje cell dendrites and they inhibit the Purkinje cells. So the ഇത്രയും നിങ്ങൾ മനസ്സിലാക്കുക molecular layerൽ you have the stellate cells and the basket cells. Both of them are inhibitory. They inhibit the Purkinje cells. These cells, basket and the stellate cells, they are stimulated by the parallel fibers. So from where these parallel fibers come? Evidna varne parallel fibers? They are the axons of the Purkinje cell. The granule cell. So granule cell, is it a stimulatory or an inhibitory cell? Stimulation or inhibition? Granule and Purkinje cell. They are both. Granule and Purkinje cell, they are both stimulatory cells. All other cells are inhibitory cells. So the stellate cell also produces GABA. Now comes the most important layer. ഏറ്റവും ഈ ലെയറുകളിൽ വെച്ച് ഏറ്റവും പ്രധാനപ്പെട്ട ലെയറും ഏറ്റവും പ്രധാനപ്പെട്ട സെല്ലും ആരാണ് ഇറ്റ് ഈസ് ദ Purkinje cell കേട്ടോ ഈ കാണുന്ന കറുത്തിരിക്കുന്ന സാധനം കണ്ടോ അതാണ് ആര് Purkinje cell മനസ്സിലായോ സോ ആ പടം നോക്കിയിട്ട് നിങ്ങൾക്ക് എന്ത് മനസ്സിലായി എന്ന് പറ ആ പടം നോക്കിയിട്ട് നിങ്ങൾക്ക് എന്താ മനസ്സിലായി എന്തെങ്കിലും മനസ്സിലായോ പിള്ളേരെ മനസ്സിലായോ എന്തെങ്കിലും പറ it is only one cell thing. It is the biggest neurons in the body and you can see here the Purkinje cell. This is a cell body of the Purkinje cell and you can see here these are the dendritic branches of the Purkinje cell layer which is extending into ഏത് ലെയറിലേക്കാ Purkinje cell ന്റെ dendrites എത്തിച്ചേരുന്നത് the Purkinje dendrites extend into which layer of the cerebellar cortex? Yes
Molecular
layer. Understood. So they have extensive dendritic branches and they extend into the molecular layer and you can see here this is the axon of the Purkinje cell and it is the only output from the cerebellar cortex. It is the only output from the cerebellar cortex. Understood? And what is the peculiarity? Purkinje cell is as such excitatory, but is it under excitation? Will it be excited normally? Normally, is it under stimulation or inhibition? Purkinje cell layer, yes, it is inhibited by which cells? Which all cells? It is inhibited by which all cells?
Basket and stellate.
Excellent, very good. Basket cells and the stellate cells. Understood. The Purkinje cell is as such excitatory, but it is under inhibition by the basket and the cellate cells, and the Purkinje cell is the only output from the cerebellar cortex. Cerebellum in the പുറത്തേക്ക് വരുന്ന ഒരു tract അല്ലെങ്കിൽ എന്ത് സാധനം, it is only from the Purkinje cell. Purkinje cell വഴിയാണ് എല്ലാ impulses പുറത്തേക്ക് വരുന്നത്. And it inhibits the deep cerebellar nuclei. DCN is deep cerebellar nuclei. Understood? Deep cerebellar nuclei. Okay. Next comes the, so below, so we have, I have told you there are how many layers are there for the cerebellar cortex? How many layers are there? How many layers are there? Which are the layers?
Molecular layer.
Which are the cells of the molecular layer? Which are the cells of the molecular layer?
Basket cells and
Basket
cell.
cells and
Basket cells. And which are the which cell forms the Purkinje cell layer?
Purkinje.
There. Which is the next layer?
Granule
The
cell.
next granular cell layer. Granular layer. So which are the cells of the granular layer? ഓർക്കാൻ ഭയങ്കര എളുപ്പമാണ്. രണ്ടും G കൊണ്ടാണ് തുടങ്ങുന്നത്. Granular G യിൽ തുടങ്ങുന്ന രണ്ട് സെല്ലാണ് ഉണ്ടാക്കിയിരിക്കുന്നത്. Which are they?
Granule cells and Golgi cells.
Granule cells and the Golgi cells. Clear? Granule cells and the Golgi cells. Okay. So this diagram is actually from Gano. എനിക്ക് തോന്നുന്നു നിങ്ങൾ ഡയഗ്രാം ബുക്കിൽ വരച്ചിട്ടുണ്ടാവും. ഈ ഡയഗ്രാം കുറച്ചൊരു കൺഫ്യൂസിങ് ഡയഗ്രാം ആണ്. എന്ന് വെച്ചാൽ ഈ Purkinje cell ലെയറിന്റെ ഏകദേശം അതേ ലെവലിലാണ് ഇവിടെ നോക്കുമ്പോൾ കാണാം അല്ലെ, ഗ്രാനുവൽ സെൽ ലെയറും ഗ്രാനുലാർ ലെയറിന്റെയും ഗോൾഗി സെല്ലിനെ ഒക്കെ കാണിച്ചിരിക്കുന്നത്. പക്ഷെ നമ്മൾ എന്താ പറയണ്ടേ, ആക്ച്വലി ഇത് രണ്ടും മുകളിലേക്കും ഇത് രണ്ടും താഴേക്കുമാണ് വരേണ്ടത്. എന്തായാലും ദിസ് ഡയഗ്രാം ഇസ് എക്സ്ട്രീംലി ഇമ്പോർട്ടന്റ് ഫോർ യു. സോ ദിസ് ഇസ് an example of which type of inhibition? Which type of inhibition? You have studied about synaptic inhibition. Yes, this is an example of feed forward inhibition. Okay, so the inhibition which is happening in the cerebellar cortex is the feed forward inhibition. So you should be very, very thorough with this. Okay, I will just rush through that. Granule cell, it is the cell body is cell body of the granular cell is present in the granule cell is present in the granular layer, and you can see that the axon of the granule cell, it ascends up and it ascends up and it reaches the molecular layer and it divides to form the parallel fibers. It forms T-shaped fibers which forms the parallel fibers, and the output of the granule cell is always excitatory. The granule cells that will just keep on exciting, which all cells? The granule cells will keep on exciting the basket cell, the stellate cell, the Purkinje cell, the Golgi cell. So the output of granule cell is always excitatory, and the neurotransmitter produced is glutamate. It is glutamate. Is that clear? Is that clear for you? Clear, Anna?
Yes, ma'am.
Yes, ma'am.
Okay. Next is a Golgi cell layer. I told you granular layer la rendu G kondu thodanguna cell la ulladu. What is the one is the granule cell and the other is the Golgi cell. So what type of cell is Golgi cell? It's a stimulatory or inhibitory? It is inhibitory, and you can see that this is the, is it axon or the dendrite? This is the dendrite. ഈ കൂർത്ത ത്രികോണം പോലെ ഇരിക്കുന്ന it is a dendrite. ഈ വാല് പോലെ ഇരിക്കുന്ന സാധനം it is the axon. So you can see here that the dendrite of the Golgi cell projects into the molecular layer. It receives input from the parallel fibers. നോക്ക് എന്തൊരു പാവമാണല്ലേ granule cell. Granule cell എല്ലാവർക്കും stimulatory ആയിട്ടുള്ള ഫൈബേഴ്സിനെ കൊടുക്കും. So that is the parallel fibers. So the Golgi cell will also receive fibers from the parallel fibers. But what will happen ultimately? When this gets stimulated by the granule cell, the Golgi cell will cause inhibition of the granule cell. Clear? Clear? And the cell body, the cell body of all this granule cell, Golgi cell, they receive fibers from the cell body receives input fibers from the mossy fiber. I'll tell you what is mossy fiber. പേരൊന്നും കേട്ടിട്ട് പേടിക്കണ്ട കേട്ടോ. The axons projects to the dendrites of the granule cell. ഇത്രയേ ഉള്ളൂ. granule cell എന്ത് ചെയ്യുന്നു? Golgi cell നെ stimulate ചെയ്യുന്നു. Golgi cell എന്ത് ചെയ്യുന്നു? Golgi cell, the axon will inhibit the granule cell. This one. This thing. Is that clear? Is that clear? Is that clear? The cell body receives input from mossy fibers as well as the dendrite receives parallel fibers, and the axon of the Golgi cell will cause inhibition of the granule cell. നല്ല അവിയൽ പോലെ ആയില്ലേ? തല പെരുക്കുന്നില്ലേ നിങ്ങൾക്ക്? തല പെരുക്കുന്നില്ലേ പിള്ളേരെ? ഇതെല്ലാം കൂടെ കേട്ടിട്ട് ഇല്ലേ? നിങ്ങൾ കേൾക്കുന്നില്ലേ? ഞാൻ പറയണ കേൾക്കുന്നില്ലേ? Okay, so we will stop here. Can I take one more minute? Can I have one more minute? തുടങ്ങിയോ? മറ്റേ ക്ലാസ് തുടങ്ങാറയ്യോ? എന്തെങ്കിലും പറ.
മാമിന് ഡിസെക്ഷൻ ആണ് മാം.
ഓക്കെ, അപ്പൊ നിങ്ങൾ എന്താ ചെയ്യണേ? പോവോ? ലാബിൽ പോവോ? Okay. I'll take one more minute. I'll stop right now. So beneath this white matter or within the white matter, so idana cerebellar gray color കാണുന്ന gray matter inner to that white matter, and within the white matter you can see certain deep cerebellar nuclei. What is nuclei? It is a collection of what do you mean by nuclei? What is nuclei? Yes,
Cell bodies.
It is a collection of cell body, and it is very, very easy to remember the deep cerebellar nuclei, that is the dentate, globose, emboliform, and the fastigial. DEFG, dentate, emboliform, globose, and fastigial. And of this emboliform and the fastigial, they are together called as the nucleus interpositus. What is it called as? Nucleus interpositus. Okay, emboliform and fastigial together you call it as nucleus interpositus. ഇത് എന്തായാലും അറിഞ്ഞിരിക്കണം, കാരണം it is very, very easy. DEFG, അതിലെ ഇയും ജിയും ഒരുമിച്ച് you call it as the nucleus interpositus. So ഈ കാണുന്നതാണ്, this is the ഈ ഒരു crumbled bag പോലെ, ഇങ്ങനെ ചുളുങ്ങിയ ഒരു ബാഗ് പോലെ ഇരിക്കുന്ന, this is the dentate nucleus, and these things are the fastigial, and this is the globose, and this is the emboliform. So these are the deep cerebellar nuclei. So the circuit I have told you, and that is very, very important. So we will stop here today. So we have discussed about the anatomy, then functional classification, and I have told you about the cerebellar cortex, the microcircuits within the cerebellar cortex, and I have told you which are the deep cerebellar nuclei. Then in the next class we will study about the afferent, efferent, and the intrinsic connections of the cerebellum, functions, and the diseases of the cerebellum. Is that clear? Any doubt for anyone? Any doubt for anyone? Shall we stop here today? No, ending ഒന്ന് പറ. Now I have we will stop here today. ഞാൻ അടുത്ത അതുലിന്റെ അടുത്ത് കൊടുത്തേക്കാം assignment. Okay, so thank you all.
Thank you, ma'am.
Thank you, ma'am.
Okay, thank you. Bye.
Thank you, ma'am.
Thank you, ma'am.